From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Hello, and welcome to this new episode of JNC Cardio Connect. I am Marcelo Di Carli. I'm the editor-in-chief of the Journal of Nuclear Cardiology. And today we have a fascinating episode where we're going to explore the intersection of vascular health, cardiometabolic disease, atherosclerosis, and advanced cardiovascular imaging. As we all know, myocardial flow reserve, or MFR, has emerged as a promising marker of vascular age, offering a physiologic snapshot of coronary circulatory function that integrates both the macrovascular and microvascular health. In an era marked by a surge in cardiometabolic conditions such as diabetes, obesity, and metabolic syndrome, identifying early indicators of vascular dysfunction is more urgent than ever. This raises an important question. Can a marker like myocardial flow reserve reveal heightened cardiovascular risk independent of metabolic disease? And if so, could it help reshape how we think about risk stratification, prevention, and the underlying biology of atherosclerosis? So in today's episode, we will unpack these questions and examine new evidence published in the May issue of the journal about the challenges that traditional boundaries between metabolic health and vascular risk pose to our field. To help me unravel these questions, we have the co-senior authors of a new manuscript that will be published in this issue of the journal covering this very topic of metabolic health, vascular age, and clinical risk. So with me today are Dr. Dan Berman, who is Director of Cardiac Imaging in the Department of Cardiology at the Schmidt Heart Institute at Cedars-Sinai Medical Center. And joining us is Dr. Dongji Han, who is a cardiologist from South Korea, formerly a research scientist working with Dr. Berman, and currently a medical resident, soon to become a cardiology fellow at Cedars-Sinai Medical Center. So Dongji and Dan, welcome to this episode, and thank you again for your time. This paper that you just published in the journal piqued our interest because it just gets to the heart of this issue of vascular age, atherosclerosis, and clinical risk. And so I thought it was a great opportunity to talk with you about what you found and what you think the findings mean for our field for the future. Dan, please give us a little bit of an introduction to the topic and why you thought of really looking at this question.
Well, thank you, Marcelo, for giving us the opportunity to talk about our paper. As you pointed out, myocardial flow reserve is of great importance in risk stratification of patients with or without diabetes. And we know that diabetics have increased risk compared to non-diabetic patients with respect to flow reserve. We also know that for any degree of perfusion defect, they have increased risk. And independently, we know that coronary artery calcium scan, a marker of vascular aging, as you have mentioned, is more predictive of risk in diabetic patients than it is in non-diabetic patients. But putting these things all together is something we don't know about. We don't know whether if you add calcium to the myocardial flow reserve, if this improves risk stratification in diabetic patients And we also don't know whether we add all that information that diabetics have increased risk compared to the non-diabetic patient. So we thought to explore these relationships or gaps in knowledge by studying a large group of patients from our nuclear cardiology and cardiac imaging registry at Cedars-Sinai to study the subject.
Thank you, Dan. Fascinating summary of the many questions we still have about how to integrate all these markers of atherosclerosis in the field. So Donty, welcome, and please give us a summary of the methodology and the patient population and what your main findings were in this study.
Thank you, Dr. DeCardi, and thank you for having us and for this opportunity. So in this prospective observational study, we included around 2,600 patients with no history of known coronary artery disease who underwent rubidium PET myocardial perfusion imaging, as well as coronary artery calcium scoring between a study period of 2010 to 2018. So for PET imaging, quantitative analysis was performed to get the ischemic total perfusion deficit, or TPD, and myocardial blood flow and myocardial flow result. And coronary artery calcium was acquired from the ECG-gated CT scan, and the primary outcome of the study is MACE, including all-cause mortality and non-fatal myocardial infarction. So now moving to our key findings. Among the 2,600 patients, about 31% had diabetes. And patients with diabetes showed higher rates of abnormal perfusion findings and lower ejection fraction and greater coronary calcification burden and reduced myocardial flow reserve. Over the median follow-up of 4.1 years, there were total 574 MACE events. Diabetes patients experienced a slightly higher MACE rate compared to non-diabetes population. In terms of the myocardial flow reserve and the outcomes, MACE rates were consistently higher among patients with reduced MFR, regardless of the diabetes status. Patients with diabetes experienced about 36% of the MACE rate in patients with reduced MFR versus 18% with normal MFR. Likewise, in non-diabetes patients, about 30% experienced the MACE events with reduced MFR versus 16% with normal MFR. And in multivariate analysis, the reduced MFR was independently associated with MACE risk. So each 0.1 unit decrease in MFR conferred 4% increased MACE risk in diabetes patients and 3% increased MACE risk in non-diabetes patients. When we look at the potential interaction between diabetes status and MFR, there was no significant interaction between those variables in terms of the prognostication. And this independent prognostic value of MFR was consistent in the analysis based on the CS burden or functional ischemic burden or TPD severity. The last special note is that when we perform the subgroup analysis based on the insulin use status, which is a well-known marker of the diabetes severity and CVD risk, only insulin-dependent diabetes had significant worse outcomes than non-insulin dependent diabetes and non-diabetic patients. So in conclusion, we found that reduced MFR is highly prevalent in patients with diabetes and is significantly associated with worsening prognosis. And the prognosis significance of MFR is consistent regardless of the diabetes status, coronary artery calcification, or ischemia burden.
I think this is fascinating because what you just summarized tell us that this marker of vascular function, of vascular age, provides independent information about the pathobiology of vascular dysfunction, which is not necessarily linked to the metabolic status of the patient. So if you're a diabetic and your flow reserve is normal or relatively preserved, you enjoy a relatively lower risk of cardiovascular events. But this is also true for the non-diabetic population. So I think this is very, very important. And it tells us that this marker will help us risk stratify patients beyond cardiometabolic disease status. So Dan, going back to you, what are the implications of these findings? And what do you think are future directions in terms of research questions? And how is this going to guide our management of these patients in the future?
Thank you again, Marcelo. All this information is very interesting, but it's hard for the doctor to put it all together in terms of coming up with assessments of the true risk of a patient, diabetic or non-diabetic. And what's, I think, exciting for the future is the work in artificial intelligence, particularly done by my colleague, Piotr Slamka, in which a comprehensive assessment of patients undergoing myocardial perfusion imaging, including not only myocardial flow reserve perfusion, but also many measurements that can be derived from the CTAC scans, not even a separate ECG gated calcium scan. So the measurements that he's doing include the calcium measurements and then organ segmentation, including chamber volumes, chamber mass, but also importantly for assessing the diabetic patient, epicardial fat, skeletal muscle, and liver fat, again, all from the CTAC scans that are routinely obtained. So these measurements are particularly important for the diabetic patient with the cardiometabolic diseases associated with it. So I think the next step would be to see if these comprehensive AI assessments show a pattern of differences within the diabetic population compared to the non-diabetic population. So that in the future, I think more studies would be needed to further explore the potential differences between these patients.
So AI will help us create some sort of a user-friendly score that will integrate all these markers that are impacting vascular function. Is that a fair summary, Dan?
It definitely is. CT coronary angiography is growing by leaps and bounds and is, let's say, getting increased prominence in the thought process of cardiologists compared to nuclear imaging. But we've never had the true power of the nuclear tests combined with imaging of atherosclerosis. And I think when we do, we're going to find out that there's much added value by knowing the changes in the overall vascular function that myocardial flow reserve gives us, as well as these other measurements that I gave that will help us have a better ability to determine which of these patients with diabetes are really at the very highest risk.
Okay, this is a perfect way to end this fascinating conversation. I want to thank both of you for your generous time today with me, and also for choosing the Journal of Nuclear Cardiology to publish this important study. Thank you again, and I hope we'll have a chance to talk about the future research that comes after this in the next few years. Thank you both very much.